Want to switch?
Okay, calling the meeting to order. It's 4:00. Welcome. This is the Indian River County Hospital District regular monthly meeting of the Board of Trustees. We'll get started with our invocation, please, Frank.
Absolutely, Madam Chair. If everyone could join me in a moment of reflection. We are grateful for the opportunity to serve, entrusted with responsibility, guided by purpose, and committed to improving the quality of life, health span, and lifespan of all those in our community. Grant us clarity in our thinking, integrity in our decisions, and the discipline to act in the best interests of many who rely on us. In a world that often feels divided, we ask for perspective. Remind us that our work, though local in scope, contributes to something much larger, a shared humanity that calls for compassion, understanding, and peace. May our actions reflect not only sound judgment, but also respect for one another, even in moments of disagreement. Help us listen more carefully, lead more thoughtfully, and remain focused on outcomes that bring stability, health, and hope to our residents. And beyond this room, we hold in mind those facing conflict, hardship, and uncertainty. May there be movement towards peace, measured not just in words, but in real and lasting change. Let us proceed with purpose. Amen.
Thank you. Pledge of Allegiance. Okay, first order of business, our consent agenda. Approval of the chairman's meeting minutes dated March 18th, regular monthly meeting minutes dated March 19th, and an April disbursement of $1,933,462.49. May I have a motion?
I have a request on the chairman's meeting minutes, and this may be just a detail I think is important as it relates to the motion pertaining to the records request from TCCH. I think it's important that our minutes clearly reflect, I think to a trustee, we all agreed that we were looking at process, not substance. And it might be helpful that the minutes clearly express that, because even at our meeting yesterday, there was some ambiguity about that. And I think since people don't always watch our meeting videos, they read our minutes, and I think to rely on the minutes so that they more accurately reflect what we intended at that time is something we need to do.
And what would you propose?
Something to the effect of, there was general discussion among the trustees that this is a request solely concerning procedures followed and not the substance or merit of any decision that was made by TCCH. And that will be a motion to amend to reflect that on page 3, the paragraph that begins with Dr. Mackett, the sentence that ends procedures right before Mr. Westcott, right there. It may be more appropriate someplace else, but that general vicinity of our minutes have it reflected there.
May I ask for counsel?
I'm just reading the particular section as well right now, but as being at the chairman's meeting last month, I do think that reflects what the intent of the request was. I know there was more discussion about what would have been received and further from that request. I do believe that that's an accurate representation of the intent of the request made last month. And since we do summary meeting minutes versus verbatim, I would say that that's an appropriate motion to amend.
Okay, well, I'd second Paul's.
So I started down the path with a motion for the minutes. Did anyone put that motion forward?
I heard Karen said, did you motion or did you make the motion or second?
So moved. Well, then
Oh.
I thought you had said
No.
motion and I said, I second. So I don't think there has been a first,
Okay.
so we can start
Do
over
you-
again.
Dana, do you?
Yes, if there wasn't a first, then trustee Westcott's motion would be the first, which is
Okay,
motion to
all
amend.
right. So the motion is to amend the minutes as trustee Westcott outlined, and we have a motion. Do we have a motion for
Now
that?
we have a motion.
Yeah, I made the motion
You made the
and
motion,
elaborated on the location as well.
and
I'll second.
you're second it.
Yeah.
Any other discussion? All in favor?
Aye.
Aye.
Any opposed? No, motion passes. Okay, now with that change noted, do we have a motion for the consent agenda?
So moved.
Okay,
Second.
okay, any discussion? All in favor?
Aye.
Any opposed? Thank you. Okay, I don't have a report, so I'll move on to Dana, please.
Thank you. Our monthly meeting packets now contain a copy of Form 8B, which is the statutory memorandum of voting conflict. If a conflict does arise in a meeting where a trustee needs to recuse him or herself in accordance with the district conflict of interest policy, you will always have that form available and on hand to fill out. The attorney's overview is now always included with each monthly meeting packet. This overview provides the summary of practices and procedures in the public meetings by the district and also sets out the parameters for public comment. All public comment shall be heard in accordance with the district's practices for calling for and receiving public comment. Communication has been ongoing regarding the amendment to VCOM's lease agreement. In accordance with the vote by the trustees at the February monthly meetings, an extension has been granted to complete this amendment on or before May 20th, 2026. We have maintained communication with the VNA regarding their request to connect to the retention pond on the parcel owned by the district and leased to Cleveland Clinic. At the current time, VNA, I had in here as this was earlier this week, had not advised of any specific updates or proposed arrangements for the trustees to consider. We did just receive a proposal from the VNA that is being summarized and then will be provided for evaluation. On the 10th Street property matter, we held a meeting with Thrive to discuss terms and conditions. It was Frank and I and representatives from Thrive to talk about the high-level terms and conditions for a potential lease agreement with Thrive for the 10th Street properties. Thrive has provided some feedback for certain milestones that they would want to see in the agreement to show their forward movement as the initial lease period progresses. I have those in my possession now, and then we'll be providing an overview, obviously, to each of the trustees to see if there is feedback, and then we will have a formal draft, which the goal is to have for review and presentation and hopefully approval at next month's meeting. In congruence with certain motions made during the March chairman's meeting, we've performed research and provided guidance on the district's authority to request certain documents from TCCH. That's all been discussed and resolved during yesterday's meeting. And we continue to work alongside district staff to review district policies and procedures, update where needed, and implement the continuing plan to accomplish all of those updates moving forward. Thank you.
Any questions of council? We appreciate that. Thank you. Michael, financial statement review.
Halfway through the 25-26 fiscal year, I'm delighted to report that the hospital district's financial position remains very strong. Let's begin our review of the March financials by turning to the last 4 pages in the financial section of your board packet. We'll start as usual with the 1-page financial snapshot of the district's cash and investments. At the top of the page, you'll see that as of March 31st, the district had received $21,016,425 of ad valorem taxes, representing 94.4% of our budget. Moving to section 1 of the snapshot, you'll see the district's U.S. Treasury holdings. At the end of March, our Treasury bills totaled $13,765,664, and they were earning an average interest rate of 3.704, slightly up from the month before. Section 2 details our holdings in the preferred deposit pool, that's the money market account, and at the end of last month, it held $4,151,734, and it was earning 3.54%. 4%. And then section 3 shows our local bank account, which was holding on that date 7/19/733. All combined, 6 months into the fiscal year, the district's investment and cash holdings totaled $18,637,131. 98% of those holdings were in some form of allowed investment. Let's go now to the next page, which is page 1 of the year-to-date expenses versus budget spreadsheet. And as a benchmark, obviously halfway into the year, if we had monthly distributions, were even over the calendar, we'd be looking at expenses being around 50% or at 50%. If you look through the spreadsheet, you'll see a handful of our funded agencies have expended less than half of their approved budget, but most have spent more than half, but to varying degrees. As I've said in the past couple of reports over the last couple of months, now that we're at the midpoint of the fiscal year, our partner agencies should have a very solid handle on what they believe that their annual expenses will be. And as I've said before, I think district staff has already been in the process of coordinating, but they'll be reaching out to all of those who are running a little hot, very hot, or perhaps even those that are a little behind, just to see what the bottom line is going to be. I'd point out a couple of things. One, you'll see the first installment finally, 6 months in, the first installment on the low income pool payments that were made in March. They total collectively just a little under $350,000. I wanted to point out one other thing. I don't think it will matter to you, but under Treasure Coast Community Health, we budgeted as such, we called it, wanted to see it in the budget, this year's contribution to the capital, their capital campaign at $250,000. The auditor and the bookkeepers basically have said this really a payable. It's on the books, but I wasn't going to change the whole document. It's going to be there. We're going to track that. And the fact is, even in the financials, they didn't completely remove everything. It was still there in drips and drabs. But again, it's just a matter of, I'll get a little more clarification from Kate after she talks to the real financial people. Moving to the middle of the last page of this spreadsheet, you'll see that the total for all program expenses at the end of March was $10,997,393. And that represents 49.5% of the approved total program budget. The bottom half of that last page shows the district's administrative expenses. You see a couple there that are big, but again, particularly the 518 or whatever it is, some ancillary costs. It's a relatively small amount of money, but it's a matter of not knowing exactly how to budget for that. Not significant. But the total through March was $898,456, and that represented 62.8% of the approved budget. So combined, hospital district's total program and administrative expenses totaled $11,895,850, which put it at the 50.3% of the approved budget. And as a point of comparison, at this point last fiscal year, our total expenses were $9,355,440 at 46.2%. With that, Madam Chair, it concludes my report. If the trustees have any questions, I will endeavor to answer them.
Any questions? Dr. Mackett?
Yes, thank you, Madam Chair. Thank you, Trustee Kent, for that excellent report. I did have just a brief question for you and then maybe one for staff. I see that we've now booked 50% of the LIP payments. And what's the expected recording of that over the next 6 months?
I'm
We
looking at
haven't paid it So that we have not received the invoices. I reached out last month, I believe, because I followed up with Michael and asked them what's going on, and they had no response. I mean, they just responded and said, we don't know. So I forwarded that communication to both the FQHCs and said, you know, this is me attempting. I would assume maybe next month.
So we just booked it for accounting purposes, but we haven't actually.
I don't know why it's.
Yeah, I'm not sure why it's booked the way it is. We did the 250,000 in capital year 2 contribution was made to TCCH, but the
The
lip
lip
payments
have
have not hit yet.
So if they're showing up on the P and L.
They are. That's the only reason.
That's okay.
Okay.
That's-
They're in my
Yeah.
report.
Yeah, we'll work that out with
Okay.
our accountants. I think that was a confusion on their part.
Okay, thank you for that. And then the other question I had related to Partners in Women's Health. And I see they're under actually quite a bit for halfway through the year. And all the reports we've had from staff and Dr. Rothman are that they are busier. So is this just a timing of invoices or?
I can speak to that, Dr. Mackett. So in fact, when you see the application this year, their ask for partners is down far below what was approved for this year. So as they get more dialed in, and they're also doing some things in terms of they had hired a third-party company who's going in for both our hospital and for Martin, who's going in and making sure that everyone who's eligible for Medicaid, gets signed up with Medicaid, and this third-party organization is doing all that. To what degree, and that's the, when I had spoken with their CFO a few days ago, that's what I was told. There might be some other factors involved in that, which I'm sure Dr. Rothman could speak to. But I will say, don't be surprised when you see the request this year, because it's down significantly from what was approved last year, which was around, I think, 4.24 million. I think this year, I don't know if Jenny's on, I think it might be 3.6 that they're asking for partners. It's down significantly. And year over year, that hasn't been the case.
Well, that's good to hear. So there's some potential billing optimization going on.
That's what I'm hearing. But I don't know that that's the whole story, but that's one of the pieces.
Thank you.
Paul?
It's an encouraging development, not just with Cleveland, but, collectively, we've been wanting to nudge our funded agencies in that direction. And this should have us that much more motivated to do that and them to be as equally motivated.
It's important.
Any other questions? Alan?
Thanks, Dr. Mackett, for pointing that out. I'd like to follow up on the partners part, only because we're at 50.1% in the total budget. When you go through the individual line items, we're over on almost every budget, almost each organization is, except for Cleveland Clinic, which is considerable, $1.5 million or so. No, about 700,000 or so below annualized figures. So my question is, do you anticipate partners remaining in at this rate? Or do you think that there's a possibility or a likelihood that they're gonna bill more in the second half than they did in the first half?
No. I mean, first of all, I think that question could be better answered from, Joe or Dr. Rothman.
Sure.
But I don't know. What I'm hearing though from my discussion is we would expect that trend to continue. Thus, the ask for next year is even less than this year. And the other thing you're going to see too with the hospital is when it comes to their intensive outpatient, their request for this year is half of last year. So they're making big strides in their behavioral health center, which from a productivity standpoint, from a billing optimization standpoint, which is affecting the bottom line, thus which is being passed to us and the taxpayers.
Well, I just further say that, congratulations to Cleveland Clinic for getting more and more efficient as taxpayers, but also citizens. I think we really, really appreciate that and admire it. But I'd also point out that based on the other agencies, there's a likelihood of supplemental requests as we move into the last quarter of the fiscal year. And we're going to have to keep that in mind, Mr. Treasurer. How you going to solve that for us?
And we've been talking around this and I'm gonna be more specific about it and I haven't talked to Jenny or Frank. But the bottom line is we say that they're investigating, they're looking, but what we very much desire is that now they are at a point where they need to be able to make the right assessment about where they're at. If they are going to be coming to us for additional dollars, we don't want it at the 11th hour. So, I mean, we can put some pressure on them to that effect so that we can have a better sense of how everything's tracking.
Yeah, these conversations are happening regularly. Shannon and Jenny are not here presently. However, the discussion, Shannon does a regular report and updates us on how everyone is tracking. We have those discussions with folks in real time. So we're still, in aggregate, we're still at budget for programs. However, we need to make sure that we're accurate on every line item.
I'd like to just share an observation, not a criticism at all. But one of the things that I've noted, and whether or not it's a function that staff has worked these up so that it appears this way, but in a sense, it's easier to come in and ask for the bump because they've run out of money than it is to actually do the ask that needs to be done. And for that reason, I'm not sure what more we can do to scrutinize the request better and more, so it's not as easy, if you will. But I just, and I don't know what it looks like,
Yeah, let me help
This
with
is, but a more compelling, factual, what have you, than what my collective memory says we've been getting. My memory may not be right, but
Well, this is, and to help with that, this is why the fee for service and changing to an encounter-based reimbursement is so important. Because if we gave someone $500,000 last year and they spent $500,000 seeing 5,000 encounters, next year, for this next budget cycle, they're asking for $1 million to see 6,000 encounters. There's a problem with that. And so without knowing how many encounters, folks are being cared for, we don't have those numbers. But this year we annualized, and Caitlin's going to give a full report later. We have 6 months of data, so we can project what the encounters are going to look like. But that's going to be our foundation, because unless someone doubles the size of a program, they hire 20 more FTEs, or something outrageous happened, there should be a proportionate relationship between encounters delivered and the cost to do that.
thank you.
Paul, clarify for me, were you talking about if our current partners come in now and say, we need additional dollars?
It is I'll tell you, I can't tell you this one or that one,
Right.
or very specific, but the connotation that I'm carrying right now is that I'll be the entity and I'm going to be overgeneralized. I write you all a letter and I show up at the meeting and say, gosh,
Right,
we were wrong. Give me more money.
okay.
And that's a gross overgeneralization.
But-
So, but
I want to make sure I understood your point that you were talking about this year, not next year's.
correct, right. I'm
Right,
just,
okay.
in years past. In
Yes,
other words,
yes.
let's look at the experience. How can we tighten it up and have some accountability on the part of the funded agencies to do better on the front side?
Correct. I agree.
Now, if on the front side, they've made an ask and we've reduced it and they come in and say, I told you so, okay.
Right, yes.
Yes.
Yeah.
And that honestly has happened once this year. I mean,
Yeah,
we scrutinized pretty hard last year based on where they were, but the program changed. They expanded the program and they did come back and ask for more money and it was sort of an I told you so, and it was appropriate. But I think by and large, you're on the point there.
Anything else from the financial statements? I have a motion to approve.
so moved.
All in favor?
Aye,
Thank you.
thank you.
Frank, Executive Director Report.
Thank you, Madam Chair. So a few of the items that I could mention that are in my report were mentioned as I work closely with Dana and Jennifer in our council report. So I'm just going to mention one item and then I'm going to have Caitlin give us an update on our statistics at the 6-month mark. So we've been talking about for some time, and we did pursue and submit our first grant application. So this was to the Bureau of Justice Assistance. So this is a grant that provides federal funding to support local initiatives led by Thrive in coordination with many community partners, which is wonderful because they have wonderful relationships with many community partners. The goal is to improve outcomes related to mental health, substance use treatment, diversion programs, and alternatives to incarceration. So these efforts are designed to reduce recidivism and improve health outcomes for vulnerable populations. For the district, this funding could potentially mean that as a government agency, we're pulling in $3 million over 3 years into this county from the Fed that otherwise would not be here. There's an in-kind portion there, which is covered by the rent abatement over those 3 years that we're going to be giving. So there's very little dollars coming out of the district budget to secure these $3 million. So we'll know September, October. I know it's August, September. It's late-ish. Before we know if we receive the award. The Fed is giving 14 of these across the country. Apparently, we have what I'm told by our grant writer who knows the space very well. We've got a 70 to 80% chance of securing it. We'll see what we get. We will keep you updated.
I have a few questions. And go get 3 million. This is not, don't go do it, critical of it, just questions that I have so that I understand. The check from the government, is it going to come to the district and we're passing it through to Thrive, or it's going to Thrive?
No, so they are going to, the way it's going to work, the mechanics of the financials are Thrive is going to spend the money. They are going to bill us. We are going to bill the Fed. And we're going to get reimbursed. That's how that works.
Okay. And
no check is coming to us to hold into an account.
Right. So the question when I read and saw, I was like, okay, well, great. We're going to get the $250,000 in rent abatement because they'll have the money to be able to do that. And I'm trying to figure out, are there other sources out there to match? I truly thought, okay, well, great, this is going to fund the project. And if I'm hearing you correctly, the rent abatement that we're giving them is going to meet the 20% in the first
Correct.
2 years and
Correct.
40%.
Yeah, the range, and we're waiting on the appraisal still for 10th Street, but that's why we had the appraisal. The 3 years is going to be between 900 and 1.26 million.
Okay. And then in looking at the description, is this going for the 10th Street project? In other words, is it earmarked for that project?
Not earmarked for any specific project, and we're not involved in the operation of the deployment of any of these activities. The responsibility is Thrive for that.
Okay.
We are we're the agency who was able to apply for this. It's really us or the county who can secure these dollars.
Right. And well, because it says, treatment services, including medication assisted treatment and recovery support. So my concern was, does that beg issues with regard to the zoning at the property in terms of our eligibility for the grant?
My understanding is no, because while these are possible components of the program, they're not required components of the program.
Right, because what I'd hate to have happen is we get the grant, whoever the grant writer is entitled to a commission, and then we're not allowed to use it because we're going to be in a situation we're going to be violating zoning. So that really needs to, I think, be addressed clearly with a legal opinion letter so that we have somebody to be accountable to us over that question.
That's a great point.
In other words, I prefer it to not just be staff. I think for something as significant as $300,000 exposure that we need an opinion letter for council so that we've got their E&O coverage to follow on.
That's a great idea. We are not committed to this at this point. We have not accepted any grant funds. We have an initial investment to write the grant, submit the grant. But that's all we have into this grant right now. We're not committed to anything beyond that. But yeah, your point is well taken. Thank you.
Okay, no.
So I'd like to, I've got a story to read on one of our presenters today, but I'd like to turn it over to Caitlin first, who's, now that we have 6 months of data through March 31st, we can annualize and take a look at what the year is going to look like, assuming the same trends continue.
All right, cool. So since we already have discussed like the budget stuff, I'm not really gonna go over that tab today since we've already talked about it. So I'm just gonna talk about the encounters and the unique individuals and how that's looked after the last 6 months. So as you can see from the chart, we're kind of starting to level out. I think now that we've dialed in with a lot of the different agencies, like what an encounter is defined as, what the fee-for-service rate is. Now that everything's kind of dialed in, I think we're gonna start seeing a lot more level set. We might end up seeing some variability. I know some of the agencies can be seasonal, as we've heard, especially probably the ones involving kids with school schedules. So that will also be interesting to see how that's going to affect it. But generally, we're starting to see it level, and it's averaging right now around 20,000 encounters per month. So we're at 124,849 total encounters. To annualize it, you can't quite just double that because as you can see, that first month was a lot higher. And then there's a couple of the different programs that had a lot in the beginning and then are not going to be the same. So I wouldn't double that, but I would say probably we're going to end up somewhere in the 200 to 250,000 encounters, 250 being probably on the max end, but closer to 200,000 encounters for the full year. And then as far as the unique individuals, we're able to track that with I would say 80 or 90% certainty. Some of the programs are groups, which we're not tracking every single person in the group. It's just a single encounter for one group. So it's a bit of a looser, unique individual count. But right now we're at almost 17,000 people, which is a lot higher, honestly, than I was anticipating. Every month, we've been seeing around 5,000 people. If you click on the month, it will filter it in the top right so you can see specifically for that month how many encounters and then how many of them were the unique individuals. So it's averaging about 5,000 to 5,500 unique individuals every month.
Now, the unique individuals every month, those are new? No. they
Not
are-
necessarily, just for that month, how many were unique. So
So I guess a question I'm asking is that, say, whole family, they have, or TCCH, or, even ourselves, SRA, we have new customers or new clients coming in. And of course, there's some leaving probably too. So you don't distinguish between who are new to their program in that
in
month?
that month, no, but the number in the corner that's like the aggregate, almost 17,000, that is truly unique for the entire 6 months. That's not just adding up 5,000 per month. That's collectively just unique
So
individuals.
that would be the.
Yeah, and so.
Would include anyone.
Yeah, when I was looking like month over month, it looked to be adding around 2,000 new unique people every month. So like the difference between 2,000 and 2,500. So if we assumed that every month we're adding another 2,500 people, I think we're going to get around 30,000 unique individuals by the end of the year. Again, it's kind of hard because I think some months we're probably not going to get quite as many. And I would anticipate as we go through every month, there'll probably be less and less new unique people because I'm sure some of these agencies are having more people coming repeatedly throughout the year. So general estimate, I would say about 30,000 by the end of the year, unique individuals.
Yeah, good work, Caitlin.
Thank you.
But just for public edification, who may not be familiar with these terms like we've gotten used to, could you define encounters for us so they know what that means?
Sure. So an encounter currently is what we would pay for the fee-for-service rate. So one encounter would be one unit of that fee-for-service rate. For every agency and every program, it's a little bit different. So some of the easier ones to kind of define are like one appointment, like a medical appointment, places like Treasure Coast, Whole Family. Some of the other ones are, trying to think of some of the weirder ones, like some of them are like medications, how many medications were dispensed. So one medication would be one encounter. So it's just kind of one unit per program that we're basing that fee for service rate on. So I would say they're all a little bit different, but that's just how we're calculating the fee for service
So
rate.
general summary of encounter means a patient being treated.
Pretty much, yes, yeah. And that is why too, the number of encounters compared to the unique individuals, 20,000 encounters a month with 5,000 people, that sounds crazy, like everyone's going a million times for a doctor's appointment, but some of them are multiple encounters for one person, so, yeah. Any other questions?
Thank you, Caitlin.
Okay.
For that. So I'd like to finish with an impact story. And this is from Caring Center for Women. This is about Brenda. When Brenda walked through the doors at the Caring Center for Women, it had been more than 10 years since her last wellness exam. At 58 years old, without insurance and juggling the demands of life that many of us have, preventive care had slowly fallen out of reach for her. But her health history, told a more urgent story. With a family history of breast and ovarian cancer, routine screenings are important. Yet her last mammogram had been over 13 years ago. At her first visit, the care team took a different approach. They treated her symptoms, but took the time to understand her full health picture, which is so important. Lab work revealed prediabetes and hyperlipidemia, both early warning signs of more serious chronic conditions. Instead of just prescribing medication, they provided education, support, and empowerment. Brenda received practical, personalized guidance on nutrition, lifestyle changes, and supplements. More importantly, she was given the time, attention, and encouragement to believe that change was possible. But the most important part is she followed through. Over the next 4 months, Brenda made meaningful changes in her daily habits. When she returned for follow-up labs, the results were positive. Her numbers had improved significantly. The progress was strong enough that the medication was no longer necessary. What began as a long overdue visit became a turning point for her. Today, Brenda's not only healthier, but more informed and engaged in her care, which is so important for all of us. She understands the importance of regular cancer screenings and is committed to staying consistent moving forward. But the most meaningful outcome goes beyond just the lab values. I'm quoting Brenda. "I put this off for years because I didn't have insurance and I thought I couldn't afford to take care of myself. Coming here changed that. They didn't just run tests. They helped me understand what was going on and what I could do about it. 4 months later, my numbers are better and I didn't need medication. I finally feel like I have control over my health again," end quote. This outcome was made possible in part through Indian River County Hospital District's investment in expanding access to preventive and primary care services for uninsured residents, ensuring that individuals like Brenda can receive timely care, education, and support before more serious conditions develop. Brenda's story reflects the broader impact of the Caring Center for Women, not just providing care, but empowering women to take ownership of their health and prevent more serious conditions before they begin. And the most important part of this is it's important for your health, health span, longevity, quality of life. But what's important also is it's a decrease in long-term costs to the entire healthcare system. And it's an honor to be part of that. So thank you. That's all I have, Madam Chair.
Thank you, Frank. One of the best parts of the job that we have is to hear from our organizations, our partners who are providing these services. So we have two this time for their semi-annual report. We'll start with the Caring Center for Women.
Good afternoon, and thank you for letting us share with you today. My name's Josie, and this is Erin. We're with the Caring Center for Women, and I'm sure you've all seen our report, but I would like to take a minute to share with you the context around what we are seeing behind the numbers, because that's where the real story lies. Based on the number of visits and patients we are seeing, the demand for services continues to be strong and consistent, and actually a little broader than we expected. What we're finding is that women rarely come in with just one need, but require multiple visits. In the last 6 months, we've provided free services to 1,196 unique women who may come in for an annual wellness visit, a pregnancy test, or an ultrasound, but very quickly, that turns into something more serious. Whether it's unmanaged blood pressure, signs of diabetes, infections, and many have experienced a lack of any prior health care. While the report shows encounters and patient outcomes, what it doesn't fully capture is that we're often stepping in at a very critical point, sometimes the first time someone's had any meaningful, compassionate interaction with healthcare system in a long time. This is where we shine, and we take this entry point very seriously. When we can see prenatal patients early, we now have the opportunity to change outcomes, and not just for the pregnancy itself, but for the long-term health of that mother. Another area we want to highlight specifically is our wellness visits. These visits are incredibly important because they allow us to identify health issues before they become emergencies. Instead of patients entering the system through the emergency room in a crisis situation, we are often able to intervene earlier, stabilize the issue, and connect them with the appropriate next level of care. That not only improves patient outcomes, but it also helps reduce the strain on the higher cost areas of the healthcare system. We've also made some very meaningful progress on the coordination side. Our connection with Cleveland Clinic through Dr. Connect has helped streamline referrals in a way that we didn't have before. We're able to get patient information over quickly and reduce some of the friction in moving the patients to the next level of care. Transmitting those records immediately while the patient is still engaged and in front of the provider reduces the risk of patients falling through the crack. We all know timing is vital in healthcare, but this is only part of the solution. One of our biggest challenges we're seeing right now is what happens after the referral. We can identify the issue and we can make the connection, but that does not always mean that patients actually get the care. There are still real barriers like transportation, scheduling delays, financial concerns, and even just navigating the system. One example that really stands out is our wellness program. About 10% of them need follow-up procedures for abnormal screenings. Those are not optional, they're medically necessary, but not all of those patients are able to complete the next step. That is where we start to see the gap between access and actual outcomes. So one of our biggest focuses moving forward is not just getting patients into the system, but helping them successfully move through the system. Another trend we're seeing, and it's a concerning one, is that patients are coming in later in pregnancy. We are seeing more and more women in the second and even third trimester of pregnancy. The challenge there is that our model is really built on early intervention. So when someone comes in late, we are doing everything we can, but it's harder and harder to catch up on missed care, missed screenings, and missed opportunities. Lack of early intervention is often tied to financial barriers and access issues. On the community side, we have really tried to stay engaged beyond just our own walls. Our participation in Trustee Alan Jones' Pregnancy Task Force has been a great opportunity to collaborate and be part of a larger conversation around maternal health in the county. Because the reality is, none of us are solving this issue, this individually. It really does take a coordinated effort. Without the financial support of the hospital district, our outreach would be drastically different. Women in Indian River County would still be going without health care they deserve and need. Being able to provide these services at no cost removes one of the biggest barriers in our patients face, and it truly changes what is possible for them. We give them hope. Looking ahead, we are at a really exciting point. With the new building, we are not just expanding space, but more opportunities will be possible. Right now, we serve as an entry point, but daily, we see the need for more. The need does not just stop after that first visit or even after pregnancy. To summarize where we are right now, I would say this: the demand is there and the impact is real, and the opportunity is in strengthening what comes next. And none of this would be possible without your support. Together, with your continued commitment to this work, we can change the landscape of women's healthcare in the Alice population and beyond.
Trustee. Dr. Mack.
Yeah, thank you for that report. That was very good, and I know the great work that you do. My question is in regard to collaboration. So I know that you collaborate well with Partners in Women's Health and Cleveland Clinic and Treasure Coast Community Health. I thought I heard that there are more women needing more specialized appointments from your wellness visits. Are you currently collaborating with the We Care Foundation?
We recently referred someone for ENT care. So yes, it's something that we're learning more about.
Good.
But we recently just did for ENT so far.
Great, because they are a good resource for indigent and underinsured patients, in particular women.
Mhm.
So,
Yeah, we'll be
good.
using them more now that we're more familiar.
Yeah, I have a question, Bill Cooney. So yesterday we approved Women's Health Fund with Treasure Coast Community Health, which they, just for clarification.
Dr. Cooney, excuse me, let me just clarify. We didn't approve anything. Yes.
Okay, we,
Right. We heard from them.
I'm sorry, we
Yes.
didn't approve it, but we discussed it.
Correct.
So my question is just for clarification. At the Caring Center for Women, you do not do mammograms or breast examinations or?
We do breast exams. And then if anyone is due for a screening or if something suspicious is found in an exam, then we do have a collaboration with Hope Imaging, and we can send the patients there for a mammogram screen, and it's no charge. That's a program with the state that we work with.
And what about cervical cancer and other female medical conditions similar?
For those type of conditions, we usually refer to Partners in Women's Health. One barrier that we're finding is that patients sometimes aren't successful as quickly as we would like with their financial assistance program. So, but that's what we work with. Mhm.
Congratulations, your growth has been spectacular over the last 4 to 5 years.
Yeah.
Congratulations.
Thank you.
Thank you.
Thank you.
Any other questions, comments? Thank you very, very much.
Thank you. Thank you.
Good report.
Appreciate you. Next, New Horizons, Greg. Welcome.
Good afternoon. My name is Greg Jackson. I have here with me Dr. Acosta Leon. Thank you for this opportunity to present just a little bit about New Horizons. We've been in existence for 67 years. We're the largest community mental health center in the Treasure Coast, actually established in Indian River upon its inception. We project to see 12,000 Treasure Coast residents this year, 2,000 of those being Indian River County residents, and utilizing the full continuum that we provide: inpatient, outpatient, specialty programs, emergency care. Basically, we're kind of considered part of the safety net for the Treasure Coast. We're on pace to utilize the $225,000 allotment from your contract. Most of that, or a lot of that utilization, is going to our mobile response team. So we have seen an uptick in those services. We have increased capacity for our mobile response team. That's essentially licensed clinicians that go out into the field to mitigate behavioral health risk, to provide linkage to care, to link individuals to care to prevent inpatient hospitalization if we can, and to also provide coordination of care after the crisis, because we know that it's critical that they obtain outpatient services as soon as possible. We've also seen an uptick in medical outpatient services because we started walk-in hours in our Vero location. So 2 days a week, I think 2 to 3 hours, to make sure the individuals can have access to psychiatric intake assessments. So those are the two trends that we have seen as far as uptick. Opportunities that we're evaluating right now is inpatient services, because we have seen an uptick in our detox program as far as Indian River County residents. We've been working closer with with Cleveland Clinic, their emergency department, to work out better referral processes specifically for our detox, to make sure that we can do a better warm handoff process. A lot of the referrals are voluntary, so we want to focus on the engagement to prevent individuals leaving against medical advice or leaving before we do the intake. So that is something that we focused on. We've also had meetings with them as well as far as children's crisis services, as far as working out a better transfer process, because like us at New Horizons, we're the only two providers in the Treasure Coast that take children age 5 to 17. So we have to work closer with them as far as addressing bed capacity issues, because if we're full, we need to be able to transfer to them and vice versa. And that's something that came about, I believe, 1.5 years ago when Longwood Pavilion in Fort Pierce, they closed their children's unit. And then JFK North down in West Palm Beach, they stopped taking children under the age of 12. So that's something that we focused on as far as being prepared for basically whatever comes to our front door as far as the needs of the children.
I have one from the report. You have on the last page, in response to what do you, as a CEO in partnership with your board, believe most striking different? You're talking about AI capability to increase for therapy and medical services. Can you talk a bit about how you're using AI?
Well, just exploring AI just to see, in general, as far as dictation to kind of help therapists with their notes and different things like that. We're also just exploring, I've talked to different providers and they're using AI more so in their units as far as being able to
update a letter.
Excuse me.
Sorry.
As far as on their units, as far as different surveillance. So, I mean, that's something that's far off that we're exploring as well, and also with billing as well. Right now, we've had a large investment into getting billers to be able to clean our claims and make sure that we don't get denials, because insurance companies are getting tighter and tighter and trying to claw back funding. So that's those are the areas where we really need to focus in to see how we can respond with technology.
Greg, how long have you been CEO?
1.5 years.
1.5 years. Glad you're still here.
Yes.
Glad you're still here. Curious, what has surprised you over the last 18 months that when you were in your previous position, you hadn't considered, or I'd just love some insights from you sitting in the chair.
Just the various needs of the different counties and communities, and just really being able to spend time with different stakeholders to, like I said, we're a safety net, so we really just need to modify our services in the different area to be able to address, I guess, the most pressing or emerging needs, because we're interfacing with the different mental health courts, with the different state hospitals, with law enforcement when mobile response goes out and they need to work with the sheriff's departments, the different police departments. So really spending the time with the different stakeholders in each of the different counties to figure out, well, what's the most pressing emergency behavioral health need, because that's our wheelhouse. That's where we really can step up. And also too, we have specialty programs where we aren't necessarily bound by fee for service, to where we can do more of like have a capitated rate that supports a multidisciplinary approach for higher need individuals. So really just being able to understand what the most pressing issue is and figure out how we can get our hands around it and address it.
I can't read you when you want to say something, or when you don't want to say something. I gotta get better at that. I'm sorry. Always putting you on the spot. Oh, but Michael would like to say something.
I want, you referenced both verbally and in your report, the increased need for children's intensive services. That's just been ongoing or you took over. Hearing you say that others have closed and it's down to, the beds you've got and locally behavioral health center. How many beds does that mean, number one? How many are not getting in to either of you because you're packed?
Well, we have 20 beds. Coral Shores, which is in Stewart.
Okay.
They have, I think, 20 beds, but they only take 12 and up.
Older.
So we have to kind of flex with them sometimes, to where if we're getting the peewees, that we call them, then we transfer to them, the older kids. So really just working closer with Cleveland Clinic, we aren't as boxed in. We just have more options to be able to transfer based on the acuity of the unit, because we don't want the distribution to be like where we have way too many big kids and then we're bringing in little kids.
Those 20 beds that you have, that's for the tri-county. That's not just Indian. In fact, we have how many nights of beds you've got slotted for Indian River County? They're not always open for Indian River County. Is that correct?
Well, we don't differentiate, but based on the data, we see we're about averaging 1 bed day for Indian River County. So about 365 bed days that we're doing.
Yeah, anecdotally, I've heard from so many different sectors, the educators, the providers, that this issue isn't going away. I'm concerned about anybody that needs significant supports, but it hurts more when I hear about kids that just can't get service.
Yeah, we've submitted a special project to become a central receiving facility, which means we just receive funding to be a more enhanced emergency behavioral health receiving. So we would be able to provide more emergency care in the screening department and potentially divert individuals, or instead of them being admitted for a 3-day stay, we observe them for 12 hours or we observe them for 16 hours. And we're able to get the psych eval done by the psychiatrist while they don't have to be admitted and wait until the next day. So that is something that we, hopefully when they come back, it's something we're pushing for.
Well, the need is there, and if we need new innovative ways to approach it, but there's just kids in need, bottom line.
Yeah. Our biggest issue on our children's unit is just our staffing, just being able to adjust our staffing to the need, because we have different drivers that are unforeseen based on the acuity, and I could let Doc speak to that. But we have various different children with different special needs. So we have to bring in additional staff to address that because they are in our care. So it's really being able to have that staffing to adjust to what, individuals that may be coming referred from the Department of Juvenile Justice. They may be a residential placement that's local. One place they bring in, they're residential, whereas kids coming from out of state. And then the kid is placed on a Baker Act and brought to us. And then we're working to try to get them back to their home stay upon discharge. So we need to be ready to address all those things. You want to say something about the kids?
Yeah.
Definitely. Good afternoon. My name is Dr. Acosta. I'm a child psychiatry. I also see adults, but I have I am a child psychiatrist because this is my passion. Yes, I saw how in an emergency room, people pay more attention to the psychiatric diagnosis than to an asthma attack. So I just refuse to continue doing that. I have a great mentor in my training. So I'm here in the Treasure Coast, try to implement all these good things that I learned in my training. Due to the reduction of the beds, yes, we are neglecting the prevention, the first point of contact. By doing that, we're neglecting our families. Yes, so if the family cannot work and the family don't have the right support, that's gonna disrupt the community. So it's not about the numbers, it's about the intensity or what is the actual, pathology of the patient. Yes, so like Mr. Jackson mentioned, if we have kids that need more care, we need to put a one-to-one for their safety. Yes, if we have a minor that need to be sent for medical clearance, we need to send our staff with them to the medical center because they are minors, they are our responsibility. So let's say in this week, we have sent couple kids to be medically clear. We have a patient that they cannot even walk, so we need to have 2-to-1 to be able to fulfill their needs and the ADLs. So a lot of people don't pay attention to that. They just pay attention to the numbers. So we are here just to help everybody to understand what it means to have a good psychiatric unit for children and adolescents. You cannot tailor the unit to one type of staff or activities. You need to actually divide the unit into and to have two different programs. Yes. There is a reason why big corporations are trying to get away of the child population. But in New Horizons, we are just trying to do better. And on top of having inpatient programs, we want to bring new outpatient programs because in that way we can prevent unnecessary hospitalizations and we can connect them right away with an outpatient program without disrupting the family. If anybody have any questions.
Yeah.
Yes, Dr. Mackey.
Yeah, thank you both for your reports and thank you and your staff for all you do. Just two questions. So I am going to speak to numbers for a minute because Mr. Jackson, I heard you say, and we've seen it reflected in our financial reports, the uptick in both the outpatient and the mobile response teams. We're going to need that quantified, and particularly if you're going to be requesting more funds for the rest of the year. And then I thought I heard you say some of the collaboration with Cleveland Clinic and the referrals for substance abuse, trying not to lose the patient because of the voluntary nature. Are you still a Marchman Act facility?
Yes, sir.
So there is the possibility that a patient could be involuntarily moved.
Yes, but for us to be able to keep them from leaving AMA, we need a higher level of licensing for our unit. So they're on the Marchman Act and they can request to be released. We just have to report back to the court that we did whatever assessment we were able to do and what the status was. For us to be able to hold them there against their will, we would need to have a different license.
Okay, thank you for that clarification.
Yeah, and just on the outpatient medical services, we are utilizing 67% more than the funding allocation. So currently we've billed 30,000 and we have 14,578 left over. So that's 67% overutilization, but we've underutilized in other areas. So that's why it evens out.
Yeah, I understand that. I guess I wasn't being clear. It'd be helpful for us to understand the increase in the actual number of patients served.
Okay.
You think you have those numbers with you or do you?
Just based on the roll-up, I'll have to dig deeper as far as each program and get
Sure.
back to you in that area.
That's fine.
Thank you.
No
That'd
problem.
be great. Thank you very much.
Thank you both.
Thank you.
Appreciate
you.
you coming. Any unfinished business? New business? Other business?
Sure.
Yes, I'm sorry.
I don't know if this is new business, but I want to make a comment that I think is worth highlighting. Trustee Prescott pointed out earlier about trying to be disciplined in the way that organizations operate and thus bill us. I just think I want to congratulate again Cleveland Clinic. And there's a couple things here that you may not know. But one is they inherited the Behavioral Health Center, which is unique in their system. They don't have that. They manage, I think, anywhere else in their system. But they inherited it. It was a loss and we subsidized them. Without any request on our part, other than the fact to be diligence, they came in and said, we have now made this unit self-sustaining. We don't guarantee it forever, but it is right now. And we're not going to bill the district as much as you've budgeted us. They did that. And you know what? Builds trust. And I think that's an important element that I want to congratulate them on. Now it turns out they've done it again in Partners in Women's Health. I, for one, was a little concerned about the soaring costs of this treatment. But on their own, they have come in and said, you know, we're running it better now and we're going to bill the district less. In the first half, I think that's like 700 grand. I mean, it's meaningful numbers. And so I just think I just wanted to congratulate Cleveland Clinic as they came into our community. It was a bumpy time, not to mention COVID. They lost quite a bit of money. It's been publicized. It'd been easy to come to us and say, these are our costs and we need more subsidy. Instead, they're working hard to be independent. And we really congratulate, maybe not totally independent, but at least directionally. And they did that kind of voluntarily on their part. And I just think they should be commended. So make that point.
We noted. Dr. Mackey.
Yes, thank you, Madam Chair. I concur with those comments from Trustee Jones. They've done an excellent job. But I do want to correct the record, though. And this is from my experience as chief of staff and still a member of the medical staff at Cleveland Clinic. Cleveland does have a very large and robust psychiatric department in Northeast Ohio. And I know that they have been working collaboratively with our teams at Behavioral Health. So I know they're working together to optimize treatment and to make things more efficient.
Okay, thanks.
And I'd like to pile on, and just from the standpoint of the two areas that you've identified, Alan, is, the third-party insurance dollars in mental health aren't easy to come by, which really accentuates the work that they've done. So thank you for bringing it up.
I don't know that this is business. It's more informational. I'll just share. I got a call from a reporter with PC Palm the day that Freddie Wolfrick passed, because he was pulling something together, and I'd known and worked with Freddie for a long time. In the course of that, he said, you know, one of the things I'm really trying to get my head around, I've been thinking about it and want to do more on just recognizing the impact of agencies and providers in town that are trying to fill the gaps. He was talking about TCCH largely, I think, whole family, and wanted to talk to me about it. I said, be happy to do that. I actually sent him to Frank. And I said, I'd be happy to talk to anybody about hospital district issues. But I sent him to Frank, and I know that he appreciated the time that Frank spent with him. And he did call me earlier this week and just spent a little bit of time on the phone. And Caitlin, you may get a call. I just referenced the data that exists and some things, and was well, without calling it up because I was on my phone, and not sitting at my computer would have been easier. The point is, I don't know what, I guess he's working on a story and, we tend to try to let Frank be the mouthpiece for the group, but, I had no difficulty in sharing with him where I was at and what I thought about the wonderful work that's being done by a lot of our partner agents. So, and again, it was the focus of exactly where we're at, working with the uninsured, underinsured Alice population. We go up to 200%. Just somebody who can provide something other than having to show up at the emergency department.
Anybody else?
Yeah, just one follow-up item from yesterday. I did speak with TCCH today, and they'd like to come to our May chairman's meeting, May 20th, the TCCH team, and talk a bit. So just wanted to share that.
I'm delighted to hear that.
Any public comment? No public comment? Then we stand adjourned. Thank you.